This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here, well not here, but at UPMC Children's Hospital of Pittsburgh at the Paul C. Gaffney Division of Pediatric Hospital Medicine. In case you're new to this, Pittsburgh has traveled. We are at the PHM National Conference in Seattle, Washington. Today we are doing a special episode on one of our more popular, or probably our most popular workshop lecture series that we had. Yesterday there was the talk on Procalcitonin, and the talk was, is it bacterial or not? When to use Procalcitonin? The speakers for the talk were Dr. Rusty McCulloh, Dr. Marie Wang, and Dr. Nita Srinivas. So this was such a popular talk, it was standing room only. And a lot of people couldn't get in. So if you're at the conference and wondered what happened because you couldn't get in, the 2 out of 3 of the presenters have been kind enough to give up their time, sit with me for about 10, 15 minutes and do a summary or a review of their talk for those of you who missed it. We are going to cover pneumonia and febrile infants on talking about Procalcitonin. They're going to do most of the talking, and we'll get underway. So let me introduce my guests. First, Dr. Rusty McCulloh is an associate professor and a division chief for the Pediatric Hospital of Medicine at the Children's Hospital Medical Center in Omaha, Nebraska. Dr. Marie Wang is the clinical assistant professor at Lucile Packard Children's Hospital, Stanford, and the associate program director for the Pediatric Hospital Medicine Fellowship there, so if anyone's applying. Thank you both very much for being here. I really appreciate it.
Thank you both for having us.
Thank you for having us.
So you guys get underway, and I'll sit in here, take notes, and I'll ask questions.
Great. So thank you for having us. So we wanted to talk today about using Procalcitonin to detect invasive bacterial infection in febrile young infants and for community-acquired pneumonia. So we as hospitalists are often faced with the question of whether or not a potential infection we're seeing is viral or bacterial, and if we should start empiric antibiotics. And biomarkers can help with this, but Procalcitonin in particular has been studied in children more commonly in Europe than in the United States. And so we just wanted to review some of the evidence for some of the common conditions that we see. Before we start, there's just a little bit of background about Procalcitonin. So in the normal state, Procalcitonin is produced by the thyroid C cells, and it's converted from procalcitonin to calcitonin, and the calcitonin is released in the bloodstream. So a normal, healthy individual should not have any Procalcitonin. But in inflammatory states, it's produced in your parenchymal tissues, and bacterial endotoxins and other inflammatory states will prompt production of Procalcitonin to be released in your bloodstream. But if you have a viral infection, this would cause production of interferon gamma, which can often inhibit Procalcitonin production. And that's why we have research showing that Procalcitonin is more elevated in bacterial states than in viral states. However, it can be elevated in non-infectious systemic inflammation as well. But we do know that it rises in peaks earlier than CRP, so it's been investigated a lot for this purpose, to detect bacterial infections. So to start off, we'd like to discuss how well Procalcitonin works to detect invasive bacterial infection or bacteremia and meningitis in febrile young infants, or infants younger than 60 days of age. So Rusty, first of all, can you tell me why do we evaluate Procalcitonin in febrile young infants?
Well, there's probably the biggest reason that we evaluate it is that it's really tough to identify young infants who actually have a bacterial infection when they're presenting with fever. And Procalcitonin, because it has this quicker rise and this ability to differentiate a little bit from viral infections, that there is a potential that it can enhance decision-making for a frontline provider. And there's been several studies that have looked at this precise fact to see where we could use Procalcitonin to differentiate a invasive bacterial infection from another non-bacterial cause of fever in a young infant. And I want to stress at the front end that when we're talking about these biomarkers, we're really talking about one of three pieces of utility. Are they a diagnostic aid, meaning do they help prove the presence or absence of a disease? Are they guiding response to therapy, so helping us decide when to stop antibiotics or to change management? Or do they provide a prognostic value, meaning that the level can tell you how sick somebody is going to be and whether they may experience a complication? For febrile infants in particular, it is to help determine the presence or absence of invasive bacterial infection.
So what does the literature show about whether procalcitonin can be used to identify invasive bacterial infection in these febrile young infants? Can it really help?
So there's a couple large-scale studies that have looked at this from a cohort standpoint. And one of those included about 1,100 well-appearing infants less than 3 months of age, so a little bit broader than the less than 60 days. And this was across 7 emergency departments in Europe. And they looked at a cutoff of procalcitonin of greater than or equal to 0.5 nanograms per milliliter. And they found it to be the only independent risk factor for invasive bacterial infection. And why this is important to separate invasive bacterial infection is because often when we talk about febrile infants, we talk about serious bacterial infections, which includes urinary tract infections. And here we're talking about the most concerning, the sickest of the sick, potentially kids, where we're looking at just bacteremia and meningitis. And it was the only independent factor among the multitude of factors that they looked at. Complete blood count, absolute neutrophil count, in terms of that. And it was an excellent marker for ruling it out, in particular superior to C-reactive protein, white blood cell count, and absolute neutrophil count, or ANC. And then there was a second large-scale study, actually with about twice as many patients, about 2,000 patients, where they had, of those 2,000 patients, about 140 who had urinary tract infection, bacteremia, or meningitis, but only 21 patients that had bacteremia and meningitis. So not a high number, and that's one of the difficulties here when we're looking for a diagnostic aid, is that the prevalence of the disease of interest is very low. And so we can get a really good negative predictive value for a test that is normal. The positive predictive value is just not going to be great because there's just not that many kids at any given time who have that disease of interest. But when we compared the performance characteristics of procalcitonin on its own with those other single measures, total white blood cell count or absolute neutrophil count or C-reactive protein, all of them performed less well than the procalcitonin alone. Now, this is not a substitute for a clinical exam and a determination of well-appearing versus ill-appearing. An ill-appearing child, the procalcitonin is almost immaterial because you're going to be treating them like a ill-appearing young infant. But it can help in those well-appearing infants where we're not sure.
So Rusty, are there any clinical decision rules that incorporate procalcitonin if you, instead of using it all by itself?
So there's actually 2 recent decision support rule systems that have been put together and published in the last few years. One is the step-by-step program, where you work through an algorithm that they included predetermined cutoffs for the procalcitonin level. And this was validated in about 2,000 infants less than 90 days of age. And this basically includes a step-by-step includes assessment of age, some clinical factors, some basic lab factors, and then blood biomarkers, which included the procalcitonin. And what we found was when you're using low-risk criteria, or what they found, and the procalcitonin, that the negative predictive value, meaning the likelihood of the disease not being present, bacteremia or meningitis, when the procalcitonin was normal in this stepwise evaluation algorithm, it was 99.3%, which is pretty good.
That's pretty good.
Yeah, the positive predictive value was not great, but that's every one of our risk stratification tools. That's the problem, and it's again because of that low prevalence. The PCARN group, which looked across 26 EDs in the U.S., looked at about 1,800 febrile infants less than 2 months of age. And of those, 30 children had an invasive bacterial infection, and they developed cutoffs for the procalcitonin as well, and as well as the absolute neutrophil count. And the procalcitonin cutoff they used was about 0.5, and the absolute neutrophil count was 4,000. And they saw, with including those factors as well as a urinalysis in evaluating for whether the child was low risk or non-low risk, that the negative predictive value was, again, about 99%, and the positive predictive value was a little bit better, 20.7. Keep in mind that it's still not as good as flipping a coin when you're talking about positive predictive value. So just because it's abnormal doesn't mean that the disease is present.
Just so I understand that, so that means the Procal had to be less than 0.5, and the absolute neutrophil count had to be less than 4,000?
Had to be
Less than 4,000.
Mm-hmm.
Okay, and then if both those criteria are met in a well-appearing infant, the chance that they have a systemic bacterial infection, meningitis, or bacteremia is very low.
Very low. Mm-hmm. That's exactly right. And a normal urinalysis. All of those together point to an extremely low risk. And most of the time when we're evaluating febrile infants, we're trying to say, who can we safely do less in? Mm-hmm. And that's where the procalcitonin may add additional value.
And in those kids, they didn't do an LP then, or they did an LP for the study, but they're saying you don't need to do an LP.
Particularly in the second month of life, that may be the case. In the first month, there's always caveats, because this is where you can miss a child even with this prediction model.
Okay.
So why don't I give you a case, Rusty? So what if you had a 35-day-old term male that presented with a fever to 38.5 but had no other symptoms, and say this baby was well appearing and it had a normal exam, and they got CBC that showed a white count of a little bit high, say 16, with an ANC of 3,500, so less than 4,000, and they had a negative UA, and you didn't have access to procalcitonin. Mm-hmm. At this point, would you perform a lumbar puncture?
That's a great question. The child's in the second month of life, and although we do have that elevated white blood cell count, given that procalcitonin, which has we do not have a procalcitonin. My apologies. If I had a procalcitonin, I'm wondering if it would help me. I would probably err on the side, though, of obtaining a lumbar puncture because of that abnormal white blood cell count.
Well, what if you had a procalcitonin of 0.2?
So that's, based on the evidence, a little bit better of a predictor, and I may be more reassured to watch that child and delay a lumbar puncture. Or to watch that child off of antibiotics. I will say the caveat is many times when we use these biomarkers, it's to help provide a justification for safely doing less when they're all normal. Some folks will use any single abnormal value as a reason to perform a lumbar puncture. But I would certainly say with a procalcitonin level of like that, even if I did a lumbar puncture, I would feel okay with waiting on the antibiotics. So I would say that if you were to summarize the procalcitonin and kind of the pros and cons in practice, either it's standalone or as part of a larger set of risk stratification tools, it's really good for identifying patients at low risk for invasive bacterial infection, bacteremia or meningitis, and it could decrease the use of lumbar puncture and definitely antibiotics when the value is normal. And it may even reduce some hospitalizations, as you may feel more reassured to have them go home and come back with close follow-up instead of observing them in the hospital. The difficulty here is, like all of our risk stratification tools, the specificity is not great, so there's a lot of potential for false positives. And the clinicians may not be as familiar with that procalcitonin, and so you may end up treating a lot of a larger number of kids if it's elevated. And then it may increase interventions if it's added on to a screening criteria and labs don't all agree. So if you had a procalcitonin that's elevated but everything else looks normal, it may prompt somebody to do a lumbar puncture who may not have had they not had that result. Because remember, the more things you look at, the more potential that you could pick up a false positive. And then there's just a lot more data that we need to get in the first month of life, which is the perennial problem with febrile infants.
Okay, so we don't know enough yet to say if you have a kid with a normal, like the example you gave, 35-day-old, full-term kid with a fever, no other symptoms, that white count, that ANC, that negative UA, you got the Procal and it was low, and let's say you even obtained the LP, we don't have enough data to say you can send that kid home. If the Procal is 0.2 and the LP has 0 white blood cells, that kid, there's no chance of SBI. We don't have enough data to do that, like with a enterovirus PCR positivity kind of thing.
Well, certainly if enterovirus PCR is positive, I think you definitely
Sure.
could. And even after you've gotten the LP, if this is a well-appearing child with those reassuring parameters and you had good follow-up, the number one thing here is good follow-up. When they do this in the outpatient setting, that's the number one predictor of whether you're coming back to the hospital, is whether you have good outpatient follow-up. If I had a good PCP, I would feel very comfortable in that low-risk setting, sending them home to follow up with their PCP the next day.
But I think even in that case, this decision rule and these data could help you make the decision to not perform a lumbar puncture in that particular case with good follow-up.
Okay, so you would not do an LP, a normal Procal, and maybe send the child, if you're going to send the child home, you haven't followed with the PCP. Or otherwise, if the follow-up's not good, or if it's weekend or a holiday, you could just watch them off antibiotics at the hospital for a little while.
Right. There's no wrong answer in this, and the lumbar puncture is always a sticky wicket. And nobody's going to fault you for attempting it. But I do think the procalcitonin may provide you an additional tool to reassure you that close follow-up without a lumbar puncture would be safe for that child.
That's great.
How about we move on to community-acquired pneumonia, Marie?
Sounds great.
So let me ask you a question here. Why would we use procalcitonin in community-acquired pneumonia?
That's a great question. So in pneumonia, one of the most common questions we ask is what is viral and what is bacterial? And to date, there haven't been great clinical decision rules or research to help us distinguish definitively who has a viral versus bacterial infection. And because antibiotics are not routinely recommended for preschool age children, I think this makes things difficult. For example, the IDSA recommends that preschool age children not receive antibiotics because they're more likely to have viral pneumonia, but I think a lot of practitioners feel uncomfortable when they have diagnosed a preschool age child with pneumonia to not start antibiotics. And so currently many children receive antibiotics for what are most likely viral etiologies. And so with something like procalcitonin that could potentially have better performance in identifying bacterial pneumonia, there's a potential for reducing antibiotic exposure.
So again, this is a diagnostic aid if we were thinking about the three roles a biomarker could play. Is that correct?
Diagnostic aid, and then some studies have also looked at the if it can be used for starting or stopping antibiotics as well.
Great. It sounds like one of the big questions here is, can you use it then to distinguish bacterial versus viral etiologies, and how do we know?
So a number of older studies have showed conflicting results, but these studies have all had various differences and methodologies and what they used for their diagnostic methods. The most robust study looking at this question is a sub-study that comes from the CDC Etiology of Pneumonia in the Community study, or EPIC study, done by the EPIC group. And they looked at over 500 children who were hospitalized with radiographic community-acquired pneumonia, or CAP, that had a procalcitonin drawn. The median age of this group was 2.4 years, and they stayed for a median of 3 days in the hospital, and 35% had ICU care. And in terms of what etiologies they found in this group, 66% only had viruses identified only, while 10% had typical bacteria identified, such as strep pneumo, Staph aureus, H. flu, and they could have also had a virus identified if they were in this typical group. 15% had atypical bacteria identified, such as mycoplasma, and this group could have also had viruses identified, and then 9% had no pathogen identified. So they took this group, they had really, really great etiologic data about what they thought was the cause of their pneumonia, and they looked at how their procalcitonin level correlated. And they found that patients with typical bacterial pneumonia had higher procalcitonin levels than all the other groups. So they had a median level of 6. And whereas the atypical bacterial group had a median level of 0.1, the viral group was 0.33, and if you didn't have any, it was 0.44. So overall, they had higher levels. But the question is, if you look at the etiology by the different levels, can that help you tell who has bacterial pneumonia or not? So traditionally, in adult studies, the cutoff people have used is 0.25. So if you have procalcitonin of higher than 0.25, you're more suspicious of bacterial causes, and if it's less, you're less suspicious. And so they kind of broke up the levels into different tiers. And so when they looked at people with a procalcitonin level of less than 0.1, a really low level, nobody had bacterial pneumonia. So in this very patients with this low level, nobody had pneumonia. When you go up to a little bit higher, so 0.1 to 0.25, they had about 7% of patients who had in this group that had a typical bacterial pneumonia. But they noted that even in this group, half of them didn't get any treatment for this presumed bacterial pneumonia, and they did fine. And as your procalcitonin level increases, you have a higher chance of having a typical bacterial pneumonia. So the highest threshold they looked at was greater than or equal to 2. In this group, 26% of the patients had a typical bacterial pneumonia. However, in this group, 66% of patients still had a viral cause. And so even if your procalcitonin level was elevated, you had a higher chance of having a typical bacterial pneumonia, but most patients still had a viral pneumonia. And so overall, they concluded that a low procalcitonin level was very good for ruling out a typical bacterial cause for pneumonia.
If I'm asking another question, would you consider that there may be a low, intermediate, and higher risk that you could break those down in?
I think that's possible. I think in this study, the group that definitely did not have any pneumonia was the group that had less than procalcitonin level of less than 0.1. Mm-hmm. So in that group, you would say it was very, very low risk. And then less than 0.25 is also pretty low risk.
Gotcha.
And then everything above that, it kind of goes up.
So low and not low, essentially.
So if I'm using this for my practice, then if I have a low procalcitonin, 0.25 or lower, especially 0.1 or lower, I'm very confident saying this isn't a bacterial pneumonia, this kid's got a viral pneumonia. Anything above that, I'm still doing what I would normally do, which is how the child looks, the assessment, and whatever my personal practice is.
Yes, that's a potential way you could use it.
Okay.
So what about using it as guidance for stopping antibiotics?
So that's a great question. So there have been a lot of studies looking at this question in adult populations, but really there have only been 2 studies looking at this question in pediatric populations, 2 randomized trials looking at if you use procalcitonin as a part of your guidance for starting and stopping antibiotics, does it change your outcomes? So one RCT was done in Italy, looked at over 300 children who had community-acquired pneumonia, and they randomized them to procalcitonin-guided therapy or control. Their control group, all of them got antibiotics because that's the guideline that they followed. And then the procalcitonin group, they checked procalcitonin every 2 days, and then if it was less than 0.25, they did not start antibiotics or they stopped it. And then if it's greater than 0.25, then they started antibiotics. And they found that in their procalcitonin group, they had a lower antibiotic prescribing rate, so about 86% compared to 100% of patients who did not have that. They had a lower mean antibiotic duration, so about 5 days compared to 11 days, and then lower rate of antibiotic-related events. And then there's a second RCT that was done in Switzerland that looked at over 300 children that had either community-acquired pneumonia or what they called non-CAP LRTI, so presumably something like bronchiolitis or something. So they took all comers with potential LRTI, which is similar to what a lot of the adult studies have done, because they're trying to identify a population for which maybe practitioners are unsure about starting antibiotics and how procalcitonin might help you. So they also randomized them 1-to-1 control, where antibiotics were initiated according to physician evaluation, and procalcitonin guided therapy, where they had predetermined thresholds in guiding them. So if it was greater than 0.25, they would start antibiotics. And then on day 5, they also checked it and they determined how many more days of antibiotics they would have according to the level. And they would discontinue it if the patient was stable and the procalcitonin level was less than 0.25. In this cohort, about half of them were hospitalized and about 64% of them had pneumonia, community-acquired pneumonia. And they found that when they looked at how many of these got antibiotics within 14 days, within the pneumonia group, it didn't make a difference. So their control groups got antibiotics 79% of the time, and their procalcitonin got it 71% of the time. But interestingly, within their non-CAP LRTI group, so presumably the group that had viral infection, there was an increase in antibiotic prescribing. So their procalcitonin group, 45% of them got antibiotics and 17% of them did not. So you're having an increase in antibiotic prescriptions in a group that presumably did not need antibiotics. And then when they looked at mean duration of antibiotics within their pneumonia group, they found that procalcitonin guided therapy did decrease days of antibiotics. So if you didn't use it, you had an average of 9 days of antibiotics, and if you did, it was about 6 days. But interestingly, within your non-CAP LRTI group, it had a slight increase in your antibiotic duration. So if you use procalcitonin, you got about 2.4 days of antibiotics versus 1.6 days if you did not.
That sounds like a nudge in the wrong direction for that group.
Yeah.
Exactly. I think this highlights that when you use it, it does have the potential to decrease antibiotic prescribing or duration in a targeted group with clearly, so such as the pneumonia group. But if you're using it in a group for which you wouldn't prescribe antibiotics normally and practitioners were unsure, it might give you the wrong guidance.
Gotcha.
That is interesting.
So let me give you a case, Marie. I have a 2-year-old who presents to the emergency department with cough, runny nose, and fever for the past 3 days, whose respiration's 30, is satting 94% on room air, has subcostal retractions and right lower lobe crackles, has a white blood cell count of 10, and a chest x-ray that shows, quote, right lower lobe infiltrate versus atelectasis. And my procalcitonin is 0.05. What should I do?
So I think the procalcitonin, because of its high negative predictive value and its high negative likelihood ratio, you could, with this information, you could be fairly certain that this patient did not have a typical bacterial pneumonia, and that would help you in the decision to not start antibiotics. I think without this information, this type of patient presents to the ER or clinic all the time. And I would say this type of patient often gets started on antibiotics. This is a very common patient for hospitalists to see. They get started on antibiotics and perhaps they don't get better. And so I think in this situation, if you had the procalcitonin, it would give you an extra piece of evidence to support your decision to not start antibiotics, to presume it was a viral cause, and to save them from the antibiotic course, as recommended by the IDSA guidelines.
So it sounds like in this case, you'd say stop. And without that information for the procalcitonin, though, you're a little bit back in no man's land.
Well, I think without that information, the guidelines do recommend that you do not need to start antibiotics.
Okay.
But I think the general culture, at least in my area, is that these patients often are started on antibiotics.
Mm-hmm. Yeah, because that's a chest x-ray that would say, please clinically correlate, and it's focal, and you've got a focal finding.
So I think this highlights, when you're thinking about if you want to implement this, you have to look at kind of what the population is that you're looking at, what your baseline antibiotic prescribing rates, and how this might influence how people prescribe antibiotics.
So what I'm learning from this, and I didn't go to your talk yesterday, is you really have to be selective about who you're going to use this in, because while it's a great negative predictive value tool, other things besides bacteria can cause a procalcitonin to go up. So if you have an elevated procalcitonin, it really doesn't point you in a direction. If you have a low one, it helps.
Mm-hmm. Exactly. So it has excellent negative predictive value and a negative likelihood ratio. And it does have the potential to decrease antibiotic prescribing and duration of therapy in CAP. This is supported, the duration of therapy argument is supported by these 2 RCTs, and antibiotic prescribing only by 1 RCT that's done in Europe. And so we don't have a ton of any data really from the US to support this. But I think there is potential to decrease antibiotic prescribing, depending on what the baseline antibiotic prescribing rate in your area is. But as you mentioned, the cons are most patients with elevated procalcitonin still have viruses, and it does have the potential to increase antibiotic prescribing if you are using it in a population where you feel like they shouldn't be on antibiotics. And there's also potential for increased lab draws too.
So let me ask one final question, and we'll get you all out here. And I appreciate we went over time, so I appreciate you all taking your time. One of the things we started with is what makes procalcitonin. And I wrote down it can be an increase in non-infectious systemic inflammation. And just so I'm clear on that, so that's things like inflammatory bowel disease, lupus, cancer. So if you have a patient with any type of inflammatory condition at baseline, the Procal could be a little bit less helpful for them.
Right. It's not going to be one that's going to distinguish definitively a bacterial infection from one of those other systemic inflammatory conditions.
And I think it's been studied mostly like in surgery and trauma and those conditions it can be elevated too.
Okay. Oh, I didn't think of that. That's great. All right. Well, thank you both very much for taking the time out. We really appreciate it. I can't thank you enough for it. I hope everyone listening enjoyed this. Thanks for being on the show.
Thank you.
Thank you.
All right, everybody. We're gonna get us out of here. Thank you to the AAP section on hospital medicine for asking us to do this. I want to thank our guests again. Thank you to the University of Pittsburgh and Children's Hospital of Pittsburgh for continuing to support our podcast. If you're in Seattle, I hope you're enjoying yourself. The weather's nice. Today may rain. And I hope you have a great day, everyone. We'll see you next time.
Thank you for listening.